My name is Kim Latchett. I am a former caregiver and a member of the Volunteer Leadership Advisory Council for ABTA. Welcome to the breakout session to treat or not to treat. There are times when treating the tumor can cause more harm than benefit, and yet oftentimes stopping treatment can be a difficult decision and perceived as giving up. This session explores important quality of life decisions when weighing the benefits or side effects of additional treatment. Our speaker today is Dr. Heather Leeper. Dr. Leeper is a neuro-oncologist who is also boarded in palliative medicine. She is passionate about improving quality of life and relieving suffering for those living with serious illness, their caregivers, and families. Her clinical and research expertise is dedicated to advancing person-centered care, whether survivorship care, supportive care, or palliative care concurrent with cancer-directed care for persons living with brain and or spinal cord cancer. Please welcome Dr. Leeper.
Hello, everyone. Thank you very much for coming today. I would like to offer that if you have questions as I go along, to go ahead and ask your questions, because we're going to be shifting through different concepts. They will build on each other like a story. So if you have questions you want to ask, just go ahead and raise them, and we'll get the mic to you. So thank you for that lovely introduction. I'm always a little shy, so I'll try and get over it. Yes, see? Okay, so is this good? Let me put it down a little bit more. How's that? Is that good? Can everyone hear me okay? Good, okay. All right, so I'm going to try and explain the biomedical model of healthcare, as well as the biopsychosocial model of healthcare, and try and explain how those things really come together in providing the best person-centered care. So when I say biomedical model of care, what I'm referring to is typical Western medicine, where, as you can see here in the Venn diagram, the disease is at the center. That is the focus. And all of the interventions by the doctors are trying to figure out how do we diagnose what's wrong, how do we identify the cause, and what can we do to intervene on the disease. So this is all in the body and the pathology of the disease. Separate from that is the concept of the biopsychosocial model of healthcare, which puts the person experiencing the illness of the disease at the center. And that, what's at the center, what's made up of those different things is the biology, the psychology, and the sociological makeup of that person. We're all different, we all are different people, and what makes us different are these different factors, our biology, but also our psychology and our sociology. So who we are, our relationships, our mental health, our personality, how do we deal with stress, how resilient are we, separate from your genetic makeup, whether you are you have a cancer predisposition syndrome or not, for example. And so I would like to posit to you all today that people with serious illness need and benefit from both models of care delivered together, that we don't have to do one or the other, that we can deliver both simultaneously. And that is because we want to be able to treat the disease as best we can and take care of the person who has the illness as best as we can. So what are some key things to know about tumor-directed treatment? So we're going to focus first on the biomedical model, okay? So what are some key things to know about tumor-directed treatment? So when you go see an oncologist, one of the key things that they want to figure out about you is what is your quote, performance status. So performance status is an essential factor in cancer care because it plays a role in both shaping someone's prognosis and determining the best treatment for a person who has cancer. Okay, so performance status is a score that estimates the person's ability to perform certain activities of daily living. So these referring to your ability to get up out of bed, get out of your pajamas, put on clothes, go to the bathroom, shower, toilet, brush your teeth, all those kind of good things. Be able to go into the kitchen, eat some food, drink some coffee, so basic functions. For people who have cancer, if you're not able to dress yourself, toilet by yourself, and eat, go into the kitchen, make yourself a bowl of cereal, pop something in the microwave, then your performance status is worrisome, that it's low. Why do we care about this? We care about this because cancer treatments are toxic. They cause side effects. They have harms. And in a lot of cancer care, the cancer care is not curative in intent, but rather palliative intent, meaning that the goal of the treatment isn't to cure the cancer, to make it go away and make all the cells be able to go away indefinitely, but rather palliative intent, meaning that we're trying to control the disease, control symptoms to help you live longer and help your symptoms be controlled, but without being able to cure the disease. And this concept applies across many different types of cancers, certainly not just those of the brain and the spinal cord. So this is a concept that's very widely practiced in oncology. So what you see here on the screen is two of the major scoring systems that oncologists use to give someone a score, so give someone a number. So this Zubrow scale is the same as the WHO and the ECOG, so ECOG. That's an abbreviation for the Eastern Cooperative Group, and that's irrelevant, it's just a name. And it says normal activity is 0, and then if you are symptomatic but you're still ambulatory, so walking around and you're able to care for yourself, then you get a 1. You're a 2 if you are sitting and resting 50% or more of the time and you need occasional assistance. A 3 if you're resting 50% of the time or more you're resting and you need nursing care, and 4 if you're bedridden. In the Karnofsky scale, it's kind of the inverse, where a high number is good. So on the Karnofsky scale, 100 is you're normal, there's no evidence of disease, and then it goes 90 all the way down to 10, with morbidin being like near death. The other things that, yes?
Is it okay to take a picture?
Yeah.
Okay.
Yep, these are all pictures from the internet, and if you need citations of where they came from, all of my citations are here at the bottom, and slides are going to be widely available, so yes, please go right ahead. You're welcome, glad you asked. Performance status matters because these factors contribute to how well or not well someone is likely to do with their cancer and tolerating cancer-directed treatments. Performance status is also important in addition to your age, how high or low the cancer burden is in your body, and any other illnesses or conditions that you might have. And performance status is so important that it's right up there with age in predicting how well someone is likely to do with cancer-directed treatment. So I can't understate how important it is. Age, you have no control over, and performance status, you also don't really have any control over. So I'm sharing these things not for you to think that if, I need to start on this massive exercise program. That's not what I'm saying. What I'm saying is that you are how you are, and I wanted you to understand why oncologists make the recommendations that they do, and this is a central tenet in the clinical care of people. So essentially, this slide is intended to show you where the cutoffs are when oncologists are thinking about treatments and what to offer, and coming up with options for people who have cancer based on their performance status. So the green arrows pointing up are intended to denote good to go for treatment. Okay, so green means go, red means stop. So on these two different scales, where you see the red dashed line and then that is the cutoff points, and the red arrows pointing down refer to that is the stop sign, where oncologists really feel strongly about hedging how much treatment to offer someone because they're really worried that the treatment would hurt them more than it would help them. Meaning that the tumor wouldn't listen very well to the treatment and you'd have toxicities, side effects, you'd feel worse, and your quality of life would get worse rather than better in totality. So another important thing to know is that regarding performance status is that clinical trials have baked into them, into their eligibility criteria, who is eligible to be on their trials, and that performance status is always number one. So again, looking back at this scale, the ECOG Zubro WHO scale on 0 to 2 is eligible, and 70 or higher on the Karnofsky scale. So again, if you're in the Karnofsky scale, if you're able to care for yourself, so do those basic things of toileting, dressing yourself, and eating, but you're not able to do normal activities, that's the threshold to be eligible for treatment. And the WHO Zubro scale, similar, it's a 2. So if you're up an atom more than 50% of the time and you only occasionally need assistance, but you're able to dress yourself, toilet by yourself, and feed yourself, you're eligible for treatment. The other important thing to know is that the recommendations that your oncologist gives you around tumor-directed treatment are based on evidence from clinical trials that form the evidence base of our practice in the biomedical model that was also based on these exact same thresholds of performance status. So when we talk about the clinical trials that inform, do we do this or this, this or this, this or this for the different diseases and the different situations that all of my colleagues are talking about? I can hear Dr. Gandhi next door. They're all anchored in the fact that all of the patients were scaled around their performance status, whether they got on the trial, and then how they did across the trial, okay? So this is central to all of the clinical trials in oncology, not just in neuro-oncology as well. Nearly all anti-tumor treatments have potentially serious adverse events. And the risks of these certain treatments in people who have low performance status can often far exceed the benefits. And this is why we have to be very, very thoughtful with you about what is going to benefit you. In some people with a brain tumor, tumor-directed treatments can improve their functional status and improve their function as the tumor responds to treatment. And that is where the art of being a clinician comes to play, is to be able to recognize who is one of these individuals who they need the tumor treatment because it will help them get better, even if it's not going to cure their tumor, versus people who have a brain tumor and that the tumor-directed treatment cannot improve their performance status or their function, and it might make them sicker and actually give them more symptoms. The other thing to know is that performance status changes over time. It's not a fixed thing. As people have gradual worsening of their cancer, often their performance status tends to go in decline with that. And that's because the cancer itself is making someone sicker, and or the cumulative effects of the cancer treatment, the side effects, the toxicities are accumulating and making the person not function as well. This is why we can't just look at an MRI and know how someone's doing, because there's a lot more going on with you than just a two-dimensional picture of your brain on a screen, right? And that's what I'm trying to help flesh out a little bit more here today in my talk. So I think it's really important that we also talk about the cancer biology itself. And what happens in cancer is that over time, when a cancer gets treated, that the cells that were able to listen and respond to those treatments die off. The cancer cells that survived that initial chemotherapy, radiation, surgery, what have you, they survive and then they repopulate the tumor. So here in this image, and the citation for it is right here, is that the orange is intended to denote different populations, in the red, different populations of cancer cells. So you can see here that as the cancer undergoes treatment, you can see how it goes from being really orange to really red. And this is intended to denote that the cancer cells that were responding to the chemotherapies, the radiation, whatever the interventions were, immune therapy, CAR T, whatever it was, that those cells will die off, and then the cancer is resettled, survived, if you will, by the cancer cells that didn't die off. And then those cells divide and then repopulate the cancer. And this is intended to depict the concept of treatment resistance, or cancer resistance to treatment. This is really the holy grail in oncology, is how to figure out how more cancer cells can be treated in the face of treatment resistance. So a lot of my colleagues and in the exhibit hall, all of these different interventions are trying to circumvent this process and trying to figure out how can we get the cancer cells to die off after they've survived all of these different things. Yeah. Yes.
On maintenance chemotherapy,
Yes.
and how effective or ineffective it is.
It's essentially the same concept, that it's trying to continue to deliver chemotherapy to cancer cells to try and continue to kill off as many of the cells that are able to be reached by that chemotherapy, that are sensitive to it. And then that's where the concept of disease progression then comes to bear, when inevitably at some point in time, the cancer cells that didn't die off are dividing and dividing and dividing, and then you have tumor progression because the cells that didn't die off and survive, that's essentially the same concept. But the concept of maintenance chemotherapy is, again, just trying to keep the orange cells down, but invariably there's going to be these red cells that are resistant that stick around. You're welcome. Okay, so, yeah, yes.
For brain cancer, some of them are different protocols. Mine is 5 days on, 23 days off. I'm trying to figure out the method, 5 and 23, what relation they have. Why 5 days on?
Why?
Yeah, and why 23 days off?
That's a great question, because when the clinical trial for that drug was developed, that's what they decided to do. Back in the day when they wrote that clinical trial, their best guess for this oral chemotherapy was to give it for X number of days and then stop, because trying to spare the bone marrow. But there's probably data from modeling in the lab that informed that decision, which is beyond what I'm able to talk about with that today. But they made the best informed decision about 5 days based on the data that they had about the pharmacology of the drug. And then that's what they did in the clinical trial, and so that's what we do today. That's what evidence-based practice refers to, is that's what the clinical trial said that we do, so that's what we all do. Okay, great question. All right. So what does this mean in terms of treatment? So putting all of this information together, Due to the evolution of these increasing tumor resistance, the cumulative adverse effects of the treatment and or decline in the person's function, their performance status, people reach a point where further treatment is much more likely to harm them than to provide them any benefit. And I think my arrows jumped around despite my best. I moved them millions of times and they just kept moving, so I apologize. These arrows are supposed to be in between here and here. I apologize. They didn't want to stay put. So when I said curative treatment, meaning that the intent of the treatment is to cure, and palliate or palliative intent to control symptoms or the spread, that's what I'm referring to with palliative intent treatment, as I mentioned earlier. So that's why all of these concepts all come together, is ultimately the question becomes in the oncology visits is what makes sense to take care of you, and what makes sense for the tumor based on its biology, where it is, and all of the treatment that you've gotten heretofore, and what is going on in your body. So all of those things together. So having discussed all of that, from the biomedical standpoint, let's switch over to talking about some key things to know when navigating decisions about your care in light of all of this. So what I'd like to invite you to think through a little bit is to step back and think about, the big picture. So by big picture, I mean, what is the intent of the cancer treatment? Again, going back to this concept, is the intent of the treatment to slow the cancer growth or the tumor growth, or to cure the cancer? So if it's palliative intent, how likely is the treatment to improve your symptoms, to control the tumor growth, to prolong survival? And if you're on this road, how's it going? If it's curative intent, how likely is the treatment to actually cure the tumor? What would be the temporary or permanent symptoms that you would have if you were to embark on this curative treatment? And if you did do all of those things, how's it going? So, and to think about what matters most, this refers to what matters most to you. Do you have any critical abilities that you cannot imagine living without? How much time away from home are you willing to spend? How will the treatment help you or prevent you from doing the things that you value most? What are the most likely side effects? What are the most likely adverse events? What can I expect will happen to me if I do this treatment? And are there logistical challenges? Meaning, how many hours am I going to have to spend in the car, in the infusion center, waiting in the lobby for this and that? And is that okay with you? Now, would it be okay with you 6 months from now? And this is all just not intended to be negative, but to be very pragmatic about you, and to respect your autonomy as a person who deserves to make their own decisions about what's important to them and to make decisions about what happens to you. This is about you and your agency and your autonomy. So us as clinicians, we need to know what's important to you to enable, your understanding about the treatments and help offer guidance around navigating decisions about what treatments make sense for you in light of what's important to you and what you're willing to go through. So this next slide is intended to posit questions for you to think about when you are needing to think about what your values and priorities are. So in palliative medicine, we go through a lot of extra training to become to really up our ante in our expertise in serious illness communication. And in those skill sets are being able to ask people to think through with us what their goals, priorities, and values are. And these are questions that I would like to share with you that we use a lot to try and get at with you in our conversations what your goals, priorities, and values might be. So as I said last slide, what abilities are so critical to you that you cannot imagine living without them? When you think about the next weeks, months, years, what do you want to be doing? What would be an unacceptable quality of life for you, or even, perhaps, for some people, life worse than death? And what matters to you most in terms of your health care? So we all have different personalities. We all have different values. We all have different cultures in our family. So what is right for you and your family is perfectly okay to be completely different than the person sitting next to you. And the goal of these questions is to just help you think through these things for yourself. And it's not intended to be a judgment of any kind. It's rather instead intended to elicit thoughts and feelings and what really means most to you. So having thought through those things, I thought it might be helpful that we talk a little bit about what palliative care is. So palliative care is really about living as well as you can for as long as you can. This is a quote from Dr. Palliative, who's the director of palliative care at UCSF, and it's something that we say a lot. We also say a lot that we are an extra layer of support for people who have serious illness and their families, because you guys have a lot going on. Physically, psychologically, emotionally, socially, you're being asked to make a lot of decisions about a lot of really big things and trying to navigate day-to-day life, and it's a lot. So palliative care tries to provide that extra layer of support for you in navigating all of this. So, oh dear, my L also disappeared. I'm so sorry. It's supposed to say physical. These are the vagaries of Google Drives. I just like to share this concept with you. And when we talk about total pain in the biopsychosocial model, and the biopsychosocial model, by the way, includes nursing care, PT, OT, speech and language pathology, physical and rehab medicine, palliative medicine, hospice care. We all practice in the biopsychosocial model where the biology of the person, their psychology, and their social dynamics all together make up the person. So, and the total pain concept is recognizing that people can have suffering, can have pain arising from those same four domains. You can have physical pain, but you can also be hurting because of emotional hurt, social struggles, and spiritual suffering. So, for example, there are people who have conditions like ALS, for example, where they're not able to move, and people would think automatically that they must be suffering a lot. Well, not always, right? And some people who have brain and spinal cord tumors, people assume that they don't have physical pain, but in actuality they do, right? So we can't make assumptions. Everyone's different, and the total pain concept is just trying to call to attention the fact that everyone's different and people can have pain arising from different domains. So people who are living with primary central nervous system tumors need their diagnosis presented in a compassionate, supportive, but also a transparent manner. They need recognition and management of complex symptoms. They need coping with grieving, guilt, anger, frustration, and loneliness that comes from having a life-threatening diagnosis and having your life change dramatically. They need support and strategies for engaging in their social roles and activities in this new context of their illness and confronting spiritual and existential issues, because oftentimes people begin to question what their meaning and their purpose is in light of what's happened to them biologically, right? So a lot of these things all intertwine with each other. They also need iterative advanced care planning discussions because things change over time. What makes sense on diagnosis day 1 might not make sense anymore 3, 6, 8, 9, 12, 14, 24, 36 months and on later, and that's okay. And I also would like to put forth to you the concept that, people also need the provision of timely and supportive end-of-life care, which may include hospice for you when that time arrives. And the caregivers of people who are living with primary central nervous system tumors need a recognition that their challenges are often very different from those of the patients, that they need anticipatory guidance around managing behavioral and cognitive changes in their loved one, as well as managing a lot of psychological, legal, and financial concerns, because oftentimes they're now the head of the family and they have to figure everything out, and it's a lot. They also need support to discuss how to take care of themselves and to also recognize their own grief, guilt, anger, frustration, and loneliness as a result of all of the things that are going on. They need direction to resources in the community and options for home health services that the doctors and clinicians can order through your insurance based on your insurance benefit options. And then they also need bereavement support should their loved one unfortunately die as a consequence of their illness. Yes, sir.
How to conduct
That's a great question. So I think that it's a complex answer because I think it depends on the context of where this is taking place in. So in palliative care, we often have access to social workers. We have access to chaplains. So sometimes if the conversation isn't evolving well with someone like me who has an MD after their name, sometimes those conversations can go very differently in a good way with someone who's a social worker, someone who's a chaplain. And sometimes those conversations don't go well because the person who has the illness has cognitive impairment. Sometimes they're embarrassed. Sometimes they're having a bad day. Sometimes they don't feel good. And they don't, like, I can't do this today. This is too much. And that's okay. So I don't think it has to be a one-time opportunity and otherwise that ship sails and it never comes back. Sometimes we can ask, this is a lot to hear. Could we talk about this some other time? How about next week? How about in 2 weeks? If you don't want to talk to me, is there someone else on my team that you'd be more comfortable talking with? So it's having some humility from our side to recognize that maybe today's not the day or I'm not the right person. And sometimes the patient isn't able to participate in these conversations because they're just not cognitively able to. That happens often in people who have brain tumors, right? So it's not unusual that the caregivers need a lot of anticipatory guidance from the team, and those conversations often happen with our nursing colleagues in addition to us when the patient is maybe at MRI, at lab, taking a rest. So we take our opportunities where we can. Sometimes that's why we end up having phone calls after clinic, because sometimes clinic is just super crazy and there's not enough time. But your question also fits very nicely into my theory that oftentimes the neuro-oncologist don't have the time nor the communication skills to this degree to navigate all of these nitty-gritties. And that's why it's good to spread the wealth of the support for the patients and their families with palliative care. Palliative care physicians often are not experts in brain tumors any more than they're experts in lung cancer or pulmonary fibrosis necessarily, but they are experts in helping people navigate stress, difficulties, getting through day to the day around all of these concepts and helping provide guidance and resources. So this, I guess what I'm saying is that it can be a much bigger team, right? Okay. So people who have a serious illness need their, and their caregivers, they need a map. They need to understand where are we now? What are our options? Like, pragmatically, what's really my options? Where do we want to go next? And if we choose any one of these different treatment options, these different directions, how fast are we going to know whether we're moving in a direction that's on an upward trend or not? What signs do we need to look for that we're actually moving in the right direction or not the right direction? The thing about having a brain tumor in particular is that the symptom burden for the person who has the tumor is really high. So I'm going to share some statistics with you. So in a group of 621 people who were collected together from across clinical trials, 75% of those individuals had a high-grade glioma. The overwhelming majority of them were white, and more than half of them were males. Half of those people reported having 10 or more symptoms at the time that they took the symptom survey. So that's a lot. And then of those individuals who said that they had, those 50% who said they had symptoms, 40% of those individuals said that they had 3 or more symptoms that they thought were moderate to severe in their intensity, not small potatoes. And here is a list of all of the symptoms that, were rated as moderate to severe. So fatigue, disturbed sleep, distress, sadness, pain, drowsiness, difficulty remembering, irritability, difficulty speaking, dry mouth. So this is a conglomeration of people who are going through treatment on a clinical trial and just trying to get through day to day, living with the brain tumor and on active treatment. So a really large burden. So I think what I'd like to help think through is that in the face of all of this physical suffering and emotional suffering, we also need to help people think about what brings them meaning and purpose, what brings them joy, and how to help people think about their flourishing in the face of what's happening. So some things to think about flourishing is, overall, how satisfied are you with life as a whole these days? In general, how happy or unhappy do you usually feel? In general, how would you rate your physical health? Obviously, in this situation, it's not going to be perfect and can be really severe. And the intent of these questions is to kind of think in terms of that total pain concept and kind of shift the thinking and thinking about how else do people derive their flourishing and their meaning and purpose. So overall, to what extent do you feel the things that you do in your life are worthwhile? I understand my purpose in life. I always act to promote good in all circumstances, even when in difficult and challenging situations. I'm always able to give up some happiness now for greater happiness later. I am content with my friendships and relationships. My relationships are as satisfying as I want them to be. How often do you worry about being able to meet normal monthly living expenses? So this gets at the financial toxicity and financial concerns. And how often do you worry about safety, food, or housing? So I'm sharing this list with you because I'd like for you to think about the fact that there's a lot to you as a person. And I recognize that, and I would like, by putting this up here and talking about it, to kind of put it out there on the open, that these are things that you as an autonomous adult deserve to have addressed, and I would encourage you that if you have issues, to raise them and say, these are things that I'd like some help with. Is there someone that I can get referred to around these things? Okay? Because you are a very dynamic person, and you have a lot going on. So I'm going to share with you here, this is the American Academy of Neurology's definition of neuropalliative care. And this was written by a whole bunch of different committees, the Law, Ethics, Law and Humanities Committee, along with the Neurological Association and the Child Neurology Society. So palliative care is an approach to medical care that aims to improve quality of life for patients with life-altering illness and their families through the prevention and management of physical, psychosocial, and spiritual suffering. Palliative care does not seek to hasten the end of life, but to help patients, people, who have the best quality of life for as long as possible, while recognizing the inevitability of death for all of us, and to provide comfort and dignity when the end of life does arrive. So I share that with you because I wanted you to know what, on our side of things, how we're thinking about what palliative care is and what we endeavor to do better in providing palliative care more. And one of the big things in palliative care, as I mentioned earlier, is serious illness communication. So just to share with you, what is that? It's a conversational approach for healthcare clinicians to listen and discover what matters most and what is important to you. It supports the shared decision-making process and to help align your healthcare goals with your goals, priorities, and values. And the topics include assessing, understanding about the disease and what the current status of the person's illness disease is, preferences about what to be told, about how to be told about medical information. So asking, how would you like to receive your information? Do you like a lot of detail, not a lot of detail? When you hear about prognosis, what is the context of the prognosis? Those kinds of things. Key concerns, such as do you have events that you're trying to make it to, priorities, worries, fears, critical abilities, family, caregiver, care partner involvement, and recommendations from treating clinicians. Meaning that, going back again to the team sport, in neuro-oncology, we always practice as a team, right? You've got the neurosurgeon, the radiation oncologist, the neuro-oncologist, at minimum, right? And so all of these different people are kind of coming up with a treatment plan. And so the idea is to, in the context of all of these different recommendations for the care of the tumor, to make sure that you are heard and seen and that you understand what's going on and what the options are. So this slide is actually a summary of a real person who was diagnosed with an oligodendroglioma. And this is a pretty typical course for someone who's receiving treatment for a grade 3 tumor. And this person, unfortunately, died 6.5 years after their initial diagnosis. And the intent of this slide was just to convey that how much treatment some people receive. And this person received 11 different treatments. So you can imagine how many different opportunities there were to talk about how are you doing? What do you understand's going on now? What treatments might make sense for you in light of where we are now and how you're doing? So in my eyes, this was 6.5 years of decision making and helping align the person's goals, preferences, and values with what their opportunities were to manage their cancer. So this slide is just intended to depict at different intervals what the palliative care conversations for this person could have been like. So from the time of diagnosis, when they first had their first craniotomy, so symptom management around having just had surgery and the craniotomy, emotional support, informational needs around the new diagnosis, the fact that their brain cancer was incurable, helping make sure that they understood the prognosis in a way that made sense to them, and managing and talking about the seizures, the new onset epilepsy that they were having as a result of the tumor. And then moving on through active treatment, so symptom management and coping through 12 months of chemotherapy, adjustments to their work and personal life balance or imbalance, as it were, information about their functional limits and what they can tolerate, what they can't tolerate, and navigating that. Advanced care planning and serious illness communication, conversations around goals, values, and priorities. And then as they went on to have even more treatment, continued symptom management, emotional support. They were experiencing worsening epilepsy, worsening cognitive, emotional, psychological, and social effects because of the side effects of their chemotherapies 2 and 3. And then as the tumor continued to progress, this person unfortunately got colon cancer. They needed iterative discussions about support and informational needs in the setting of having worsening seizures, getting a second surgery, more radiation, and yet another chemotherapy. And then ultimately, this person enrolled in a phase 1 clinical trial. And then that clinical trial ended for that person because they progressed. And then this person got diagnosed with stage 3 colon cancer. The goals of care conversations continued, trying to understand what treatments would make sense for him in light of the fact that now he also has colon cancer. And then ultimately, within 6 months or so of their death, they had some pretty significant conversations around changing their code status to do not resuscitate, do not intubate, and de-escalation of care in light of their limited prognosis. And ultimately, this person enrolled in hospice and died at home with their spouse and family members. So this was just intended to kind of give you a landscape of if palliative care is involved, what does that look like? So I'm sure you're all wondering then, what in the world, Dr. Leeper, is hospice care? You talk a lot about palliative care, but what's hospice care? So I wanted to make sure I covered that for you as well. So hospice care is both a care philosophy and a healthcare service. So how palliative care and hospice care are similar is that they both aim to provide as much support of the person and their quality of life for as long as possible to keep them comfortable and have their care aligned with their goals. Hospice care aims to provide comfort through maximally treating symptoms and focusing on quality of life when that person has decided that continuing on restorative care, cancer treatments, treatment for infections, and things of that nature are no longer helping them. Leaving home and going and sitting in the doctor's office in the emergency department isn't meeting their needs anymore. And also because the doctors are now telling them there's really nothing that's going to substantively change if you do yet another drug, yet another antibiotic. An important thing that to know about hospice is that it does not provide 24-hour custodial nursing care. It doesn't cover room and board, and it doesn't cover medications that are not related to the diagnosis that's making them hospice eligible. So some nuts and bolts of hospice, like where and who pays. So hospice is overwhelmingly provided at home here in the United States. It can also be provided for individuals who are in a nursing home and an assisted living facility. Basically, hospice will go wherever you are. But they do not provide your room and board. They don't provide the nursing care around the clock. People who are in inpatient hospice units are there because they have a symptom that needs to be actively managed, and that is up to the hospice to determine. And some hospices have their own facility that they can admit patients to, and some hospices have contracted beds in certain healthcare institutions. Who pays? It's an insurance benefit here in the United States. So anyone who has Medicare has hospice. Anyone who has Medicaid has hospice. Hospice is almost always included in all private insurance plans and HMOs. It's really rare that someone has no hospice coverage with their insurance. Hospices often provide charity care for people who have an inability to pay or inability to verify that they're, irregardless of their citizenship status. So some other things to know in terms of hospice is who's eligible. Anyone estimated by physicians to have a life expectancy of 6 months or less if their illness were to run its natural course. So this is true of all illnesses. So this is not just specific to neuro-oncologic diagnoses, but in general. So the focus is on caring for the whole person and their family, the caregivers. And like I just said, the win is when a person decides not to pursue disease-directed healthcare in order to focus on maximizing their symptom management, their comfort, and quality of life, staying home. Again, because the disease-directed healthcare is not benefiting them or will not benefit them, and that the burdens of those treatments outweigh their benefits. With that, I have the usual disclaimer. Thank you very much for your attention, and at this point, I am wide open for any questions that you might have.
Thank you for your work in this area because there's not much of it to find. So am I correct in the 12 items you had out there were the 12 items from the Harvard Human Flourishing part? Okay.
That's from a publication, yes.
Yeah, okay. So my question is, like I worked really hard. I've come out of a student development and higher education background and stuff like that, and psychology, behavioral science background.
Wonderful.
So when I went in my treatment, I found lots of things about overall survivability, more things about progression-free survival, almost absolutely nothing about overall health care, and nothing about flourishing in any of the things. But I've made most of my healthcare decisions based the opposite way, starting with what the flourishing things are. How can we get a healthcare professional to talk about whatever they're suggesting based on the other way on the scale? How does this help me flourish? How does this overall health, not how long I'm going to live or whether it's going to progression-free survival, but if your things are more important on that other end, how do you get them to talk about it that way?
I have spent many, many hours agonizing over that exact question. What I can say is that there's a handful of us that are like me that are dual trained, and we are, I'm working right now on an international group to agree on outcomes for palliative care clinical trials, including questions like this, so that when we do research moving forward, and we're involving lots of patient advocates to figure out what of these questions should we include in this core outcome set, so that when we start doing clinical trials, that we have that in there, because what will make the difference for physicians is once there's evidence behind it that this is what the patients want. So I'm working on it. You're welcome.
Thank you. I want to invite you to come to UCSF and talk to us about what we have going on there. I'm a 14-year, almost 14-year patient with oligo, and so I'm part of a very intense peer-to-peer support group. And let's see, we've been going on for about 4.5 years. And unfortunately, I think we've lost 3 patients, fellow brain cancer patients in the last 15 months. And one of those people, a really wonderful guy, who I miss almost every day, and challenged us as a group to do last September, before he died, to do more to reach out to caregivers. And so I'm not really sure how this fits into what you were just talking about, but there's a lot of misunderstanding around palliative care and all the rest. And in my particular case, I'm unable to convince my wife and my 29-year-old, much smarter than I am, Chance, what it really means, because I'm looking at that myself. I have to prepare. And how do I get them to prepare? And this goes back to my fellow patient last year saying, among my group, the 25 of us, we must do better to support our caregivers.
I agree. I think that in palliative care and in hospice care, for those of you who are interested, the focus is not just the patient, but their whole social dynamic, because we realize that without the caregiver, there's a lot missing, right? So it's an incomplete circle. So I think that I have other colleagues like Dr. Logan, who's speaking. She's a neuropsychologist who specializes in support, and she's working on caregiver support. So there are those of us who are trying to really dig into the caregiver issues, and I try and talk about them as much as I can, like this, because I do agree with you 100%, and that caregivers are really important. And I would love to support whatever work can be done that elaborates that from the patient side that they want these conversations. I think there's a lot of concern on behalf of the clinicians that these conversations will hurt, that it will diminish hope, and people are worried that they're going to inflict harm, and so they just don't want to talk about it. But I think that when we frame things around, we're here to support you wherever you are and come alongside you wherever you are, is a really different conversation. So this is why I shared with you the palliative care definition and things, because I want you to know that this is where we're coming from, and we'd love to know where you're coming from so that we can put that out there, that we're trying to meet people where they are, and that it's not just coming from us, we're not forcing something.
So I think that's all the time we have for questions today. Thank you, Dr. Leeper, for this wonderful session on quality of life and treatment.